Hello, future nurses. My name is Arteriole, and I am the ultimate traffic controller and pressure regulator of the cardiovascular highway. If you recall our past discussion on the circulatory system, Madam Aorta and the major arteries are the giant high-pressure superhighways. I, on the other hand, am a microscopic branching vessel that connects those large arteries directly to the delicate, single-cell thin capillary beds. Because I bridge the gap between high pressure channels and fragile exchange zones, I am structurally classified as the primary resistance vessels of the human body. In your nursing lectures, you will see me heavily featured in blueprints regarding blood pressure regulation and shock. My primary mission in life is to dynamically alter my internal diameter to control exactly how much blood flow a specific organ receives, while absorbing the high pressure pounding of the heart so your patient's capillaries don't explode. Anatomy and physiology, the power of the smooth muscle. To understand how I dictate systemic blood pressure, you must look at my unique structural blueprint. Unlike capillaries, which are just a single layer of endothelial silk, my tiny walls are wrapped in a highly responsive, thick circular layer of smooth muscle. This smooth muscle layer is packed to the brim with autonomic nervous system receptors, alpha 1 and beta 2 adrenergic receptors. Because of this design, I can physically alter my internal pipe diameter within milliseconds through two opposite structural states. 1. Vasoconstriction, the tight squeeze, when your patient's sympathetic nervous system fires, the fight or flight response, or when hormones like norepinephrine, angiotensin II, or ADH flood the bloodstream, they bind to my alpha 1 receptors. This commands my smooth muscle ring to violently contract and narrow my internal diameter. The clinical result, this creates massive friction against the passing blood, a concept known as total peripheral resistance, TPR, or systemic vascular resistance, SVR. By tightening the nozzle on the pipe, blood backs up into the major arteries, causing the patient's systemic blood pressure to skyrocket. 2. Vasodilation, the open valve. When the sympathetic nervous system calms down, or when local tissue factors notice a drop in oxygen or a buildup of metabolic waste, like nitric oxide, lactic acid, or hydrogen ions, my smooth muscle completely relaxes, opening my internal diameter wide. The clinical result, resistance drops to near zero. Blood rushes effortlessly out of the large arteries and floods into that specific local tissue bed, instantly lowering the systemic pressure behind it. Image demonstrating the cross-sectional difference between a vasoconstricted arteriole and a vasodilated arteriole. The major functions of arterioles. For your proctored nursing examinations, you can summarize my two vital responsibilities into determining afterload/blood pressure and diverting blood flow autoregulation. 1. The main determinant of systemic afterload. In your cardiac modules, you will learn about afterload, the amount of resistance the left ventricle must push against to force blood out into the body. Because I sit right in front of the capillaries, my collective state of constriction or dilation is the number one factor that creates this resistance. If I constrict body-wide, afterload spikes, forcing Mr. Heart to burn massive amounts of energy and work twice as hard to pump blood. 2. Selective blood shunting, tissue perfusion. I act like a smart plumbing grid that routes blood only where it is actively needed. The exercise shift. If your patient is running on a treadmill, the arterioles feeding their gastrointestinal tract and kidneys will sharply vasoconstrict, turning off blood flow to those non-essential organs. Simultaneously, the arterioles weaving through their skeletal muscles and heart will heavily vasodilate, routing almost 80% of the cardiac output straight to the working muscles. Common pathologies, the collapse of resistance. When my smooth muscle rings lose their tone or dilate inappropriately body-wide, your patient faces immediate life-threatening perfusion failures. 1. Distributive shock, the wide-open pipes. This is an absolute top-tier favorite for advanced med-surg nursing blueprints. In forms of distributive shock, specifically septic shock, driven by bacterial endotoxins, or anaphylactic shock, driven by massive systemic histamine release. Belligerent chemical mediators travel through the blood and force every single arteriole in the body to vasodilate completely at the exact same time. The crisis. Because all my resistance valves open wide simultaneously, the systemic container becomes too large for the blood volume inside it. Total peripheral resistance collapses to zero, causing the patient's blood pressure to crash into a bottomless pit, severe hypertension, starving the brain, kidneys, and heart of perfusion. 2. Chronic hypertension damage. If a patient suffers from chronic, unmanaged high blood pressure, the constant high-velocity pounding forces my smooth muscle layer to undergo hypertrophy and thickening to protect itself. The complication: this thickening makes my walls stiff and permanently narrow. Arteriolosclerosis. This is highly destructive in the kidneys, where narrow arterioles restrict blood flow to the nephrons, leading to chronic renal failure. Critical nursing assessments and implications. The mean arterial pressure, MAP. Target: because arterioles control the resistance that keeps blood moving during diastole, they are the main drivers of mean arterial pressure, MAP, the average pressure pushing blood into vital organs throughout the entire cardiac cycle. The target: as a nurse, you must calculate or track the MAP on your monitor. A healthy MAP must sit strictly above 65 millimeters of mercury. If the MAP drops below 65, because arterioles have vasodilated in shock, there is not enough resistance pressure to shove blood into the kidneys and brain, leading to acute organ failure. The vasoactive medication protocol, vasopressors. If your patient is in septic or anaphylactic shock with a MAP below 65, your highest priority advanced pharmacology intervention is the continuous IV infusion of vasopressors, such as norepinephrine/levofed, epinephrine, or phenylephrine. The action: these powerful drugs travel straight to my smooth muscle alpha-1 receptors, forcing my wide-open valves to violently vasoconstrict. This instantly clamps the container down, driving total peripheral resistance and blood pressure back up to safe organ perfusion levels. The nursing rule: vasopressors are highly vesicant. Always prioritize infusing them through a central venous line rather than a peripheral IV. If a vasopressor leaks into the local hand or arm tissue, extravasation, it will cause my local arterioles to constrict so tightly that all local blood flow will halt, causing the surrounding skin to necrose and die. Always monitor your IV sites intensely. Follow us on YouTube. Felix K's Explore for more. Otherwise, like, share, and follow us if you enjoyed the class. Thank you for your support.